At the outset, I would like to thank Entod for the support for simultaneous telecast on YouTube, Facebook, and online channels. At the same time, I'd like to thank Dr. K.K. Mehta, Dr. Bruce from US, uh, then Dr. Matthew Martin from US, Nitesh Barot from UK, and Dr. K.K. Mehta, Padma Shri, Dr. K.K. Mehta, and Dr. Kuresh Maskati, and myself from India. So let me start with introducing the speakers. The first speaker today we have is Padma Shri Dr. K.K. Mehta. He's an ophthalmologist, medical researcher, and a writer. He is considered as a father of phacoemulsification in India. He is recipient of several honors, including Grand Honors Award, National Eye Research Foundation, Chicago, Triple Ribbon Award of American Society of Cataract and Refractive Surgery. He has been honored the highest civilian honor of India, Padma Shri, in 2008. Uh, then we have Dr. Bruce Williams. He's an OD, fellow of International Academy of Orthokeratology, practices in Seattle, and has an emphasis on complex contact lens fitting, including orthokeratology. He is actively involved in clinical trials for several contact lens manufacturers. He has published and given lectures all over the world, conducted a lot of workshops, more than 30 cities in 5 continents. Dr. William is a member of American Optometric Association, the Cornea and Contact Lens section of the AOA, British Contact Lens Association. He is reviewer of contact lens and anterior eye and Journal of British Contact Lens Association. He is adjunct professor at the University of Missouri, St. Louis College of Optometry, and Western University of Health Sciences. He travels to Bangkok, China, Hong Kong, travels to all over the world. As you saw, he's given lectures in all 5 continents. So we welcome Dr. Bruce. Then we have Dr. Nitesh from UK. He is president of British Indo-Pacific Orthokeratology Myopia Control Academy. He's been instrumental in conducting and introducing orthokeratology and myopia control in India since last few years. He has a special interest in advanced soft and rigid contact lens fittings with special focus on orthokeratology and rehabilitation of traumatized and irregular corneas. He is the Executive Secretary of International Academy of Orthokeratology and Myopia Control. He is a founding member of Euro OK. He is an international lecturer, mentor, and examiner for FIAO. Nitesh graduated from Aston University and is a member of British College of Optometry. Then we have Dr. Matthew Martin, very famous orthokeratologist and myopia control specialist from US, Michigan. He has been practicing orthokeratology since last 17 years. He has passion for education and has served as a mentor for many doctors on myopia management. Dr. Martin speaks nationally and internationally on subject of myopia control with an emphasis on ortho-K. His most recent international lecture was in Mumbai, India in 2019. Then we have Dr. Kuresh Maskati, my godfather and mentor. He was president of AIOS, that is All India Ophthalmological Society, 2014-15. President International Society of Manual Small Incision Cataract Surgery, 2017-19. President Cornea Society of India, 17-19. President of Bombay Ophthalmology Association, 2000 to 2001. President of Maharashtra Ophthalmic Society. He was the youngest president of Maharashtra Ophthalmic Society in 1995-96. Is the chairman of FBSAIOS 2019. He is the only ophthalmologist in the world with the experience of performing Boston keratoprosthesis as well as Pintucci keratoprosthesis. He has given lectures all over the world. He has performed surgeries in many countries. He was ophthalmic advisor to Sight Savers International, formerly Royal Commonwealth Society for Blind. He was advisor to Queen Elizabeth Trust National Task Force on Diabetic Retinopathy and convener of AIOS diabetic eye screening clinics in India. So I welcome you all for today's webinar on myopia control. I request Dr. K.K. Mehta to give his presentation now.
Thank you. I'll share my screen. It is indeed lovely being here in such an August gathering with Bruce, Matthew, and Nitesh, and of course uh, our local faculty. It's indeed a pleasure, and I'm most happy to be here with you. My job is very simple. It's just to get you started into the entire one would say the entire work, and then it will be taken over by our senior speakers who are there. So rather than going around in circles, I'm going to start off. Now, when we first talk of myopia, the first thought goes to its effect on children. And the main concern and worry of children, of parents essentially, is how do we stop and slow myopia in children? The prevalence of myopia in children is getting to be extremely widespread and is increasing day by day. Myopia becoming a worldwide epidemic. And if we just look at the prevalence in the map, you notice it's literally all over the world. The areas where you see green, in which India, of course, ranks foremost, is the patients where you have more than 70% of myopia running. The prevalence of myopia is progressively increasing, and over the next few years, if you see the graph, it's almost sliding all the way up. It's almost a 45-degree graph angle. And the march of myopia in various countries all over the world is equally well reflected. And one thing which worries us is not so much the increase in myopia as the lower graph on your right hand side, where you see the high myopia cases are progressively increasing too. And the main cause of worry, I said, is just now that the age of onset has become younger. It is now has a faster progression than what it used to be in earlier days. The older age of myopia stabilization is getting later, with at a higher level, and significantly increased risks and complications. Now, when we talk about children and e-gadgets are literally inseparable. And what we were always worried about is we have these children playing with these toys more and more. And it is now becoming what we literally call as a digital vision syndrome rather than computer vision syndrome. One big problem with children is the size of the screen is there, and children hold it closer purely because their arm lengths are shorter than that of an adult, which makes them focus more. The accommodation increases, so they tend to get headaches and fatigue more often than adults do. Now, all schools and colleges, at least all of them who pride on being at the top of the podium, literally now give almost all their work and schoolwork and even take their homework literally online. However, it is to take care of the child's eye that we have to take care of a few fundamental concepts which I will bring out. One is, of course, convergence fatigue. We know that increased convergence is going to lead to a problem, and of course, the insufficient blinking, which causes the headache. Fundamental things we have to make sure our children have is that they take a break from a screen every 10 to 20 minutes. Children, once they hold a mobile in their hand, it seems to be stuck onto their hand. They just don't move, they don't look at anything else. You have to be sure that you maintain the proper screen and monitor hygiene, and most important of all, limit screen time down on the phone. You have to tell them that look, you look at other things also. Otherwise, once children have a phone in their hand, they look nowhere else. You need to explain to them that they need to take a break from the mobile devices like iPad, etc., and use it for essential activities. And games should be restricted. A little bit of parental care is required. And every half an hour or so, let them put their mobiles down, walk around, give them a bit of a break from the excess amount of convergence which is being overloaded. And once again, to bring out our old non-electrical games, which all of us were basically raised on, but nowadays children don't even know they exist. So I mean, these things need to be brought out so that they can spend more time on games which, especially in these days of lockdown, where they do not unnecessarily overload their convergence mechanism. You need to teach the child to do one fundamental thing, what I call as the slow blink. Slowly open and close the eyes, blink it 10, 20 times at regular intervals. That tends to take away a lot of the eye strain. The conversion of childhood to high adult myopia is now becoming a big problem for us and will be spoken a little later by some of the speakers. And it's about the age group is now growing comparatively younger. And thus, some of the factors which lead on to this conversion to high adult myopia is a parental myopia, a younger age at the baseline, and a greater amount of time spent for near work activity. Let us quickly look at the causal relationship of electronic visual aids, children, and myopia. A study which was done in China showed a study was quite extensive of 566 children, showed that there was a significant correlation between the use of these devices and the spherical equivalent refraction. The workers almost evaluated out and said that it tends to increase significantly if you evaluate it over a period of time, and the more time spent on the near activity, the greater is the spherical equivalent refraction, which tends to go up. Now there are four. Now one of the key problems we need to bring out and tell our patients is the four key hidden problems of vision in children, which they need to look into and remember. Having a child which seemed to have been working well earlier and now having a short attention span, seeming to quickly lose interest in games, projects, or activities, is an indication that there may be a change in the spectacle power of his eye, and this child needs to be evaluated. Some children will lose their place when reading. When they read, and you will notice they tend to skip words, or they've started holding a pen in their hand, as you see this child, just to track where they are on the page. And some of the children will just avoid reading and will seem to be, like making trouble all the time. The same children who are very good earlier, and these are the children we need to look up and find out as to what is exactly happening. And these are the children who tend to go on to high myopia levels. So the big problem is now when we talk of myopia progression, I'm just going to introduce the topics to you. They will be taken up in much greater detail very shortly by some of our top speakers who are with us today. And one of them is orthokeratology and multifocal contact lenses, use of atropine, and of course exposure to the great sunny outdoors. Ortho-K, as you're all aware, is basically the use of specially designed GP lenses, which are now completely computer designed and work extremely well, and are the techniques of applying so that you resurface the cornea. Very often you need to only utilize it at night when you sleep. You don't need to wear them the full day. And the new advent is also that we are laying more and more stress on the use of multifocal contact lenses and eyeglasses. There are progressive editions, and there's been quite a trend now of having children which has shown that there is significant less myopia progression and reduce in the axial elongation if they have are wearing progressive edition lenses. And this was a controlled trial done in Hong Kong. Of course, atropine, which came about 2 years ago, 2 years or 2.5 years ago in India, we've had extremely good results with it. As a matter of fact, I find that it works extremely well. There are a few drawbacks to the atropine treatment, basically discomfort, light sensitivity. But 0.01%, which in my hand works well, I have found does not have much of a hassle or difficulty. The important thing is it should be put lasting at night before the child sleeps, and after that near point activity should be restricted. There has now been a significant amount of research which also shows that outdoor intervention reduces the incidence of myopia by spending a child outside. A very nice study which was done by Ho and Wu showed that just a minimum of 120 minutes per day, basically 2 hours a day, if the child is outside, walks in the sun and plays in the sun, myopia does not tend to progress so much. And We feel that probably the reason why this helps is it increases the dopamine level, it decreases what we call as image blur, and perhaps the chromaticity of the sunlight is more important. And the more when since you outdoors, you're in a larger dioptric space with outdoor play activities, the eye gets a better chance to relax. Now, the question always asked is children and TV. Children, when they stand, are always come very close to the television, and the popular belief is that it really affects the eye, which is not really true. And you do have to be sure that you maintain the basic guidelines of television, which is essentially to sit to 2 and 2.5 times the diagonal screen distance. But it tends to overload the eyes. You must understand that this activity essentially causes the eye to get tired. But after you watch television, then if you do near point activity where the convergence is stressed, there's a likelihood of myopia increasing. Video games for children, yes or no? In the earlier days, all parents thought they were time wasters, and actually people thought it made the child more violent. But now we are learning over a period of time. It makes the children smarter. It increases hand-eye coordination, sharpens cohesive skills, decision making, and actually, if anything, may teach children high-level skills. Ideal, of course, for amblyopia training and exercises. And in the end, you have to, I'll close by mentioning the WHO guidelines, where it says that we should tend to restrict the use of digital screens between the ages of 2 and 5. I know it's difficult at the present moment. And that the blue light exposure at night from computers also alters the, the melatonin activity, which makes a child remain awake at night. And hence, better to call off screen time at least 1 or 1.5 before bedtime. Thank you for your attention. Back to you.
Wonderful, Dr. K.K. Mehta. Thanks for the insight. And as we see, every continent is going through COVID, and due to lockdown, I guess most of the children are indoor. And once everything is open, I think we are going to see sharp increase in the myopia progression in these children. That's what we are worried about. At least in India, we are now almost 2 months closed and indoors, so children are not going outdoors. Plus, 40% of the screen time has increased, and that is another concern. So, thank you, Dr. Keki, for your inputs. Now, I will give my presentation on understanding myopia control. So, of course, everybody knows what is myopia. So what another things for the freshers who are new to these students, 2 3 terms they should understand is myopic defocus and hyperopic defocus. Of course, axial length. There was one question on the panel, how to measure axial length. Of course, you can measure with a scan, or if you are with the ophthalmologist, you have a you know the instruments to measure the whole of eyeball. So simple, myopia progression equal to single vision glass. I know I'm making a bold statement. Many of you may be surprised, but this is a fact. The moment you prescribe single vision glass, you're pushing that child into myopia progression. Why? Because of the hyperopic defocus caused by the image shell. I'll explain that in a later slide. So the child who is starting with very small number is going to look like this. So this is what I'm talking about. When you give a single vision correction, the image shell which is forming here is going away. It's forming out of the retina, and the peripheral retina, it is forming outside, which is causing a hyperopic defocus. And that gives signal to the brain that to increase in that direction. So this is the concept. Another concept that we saw is the myopic defocus. So this is a hyperopic defocus which is forming outside or behind the retina. Of course, it doesn't form behind the retina, but it is a defocus formed kind of hyperopic. Now, why we are worried about myopia progression or axial length? Because of the comorbidities associated with that. The moment there is axial elongation, there is a stretch and stress on the retina, and that can lead to early cataracts, glaucoma, macular myopathy, and retinal detachment. So, of course, cataract is not that severe because of surgical techniques that are there. But to get a cataract at the age of 45 or 50 or 55, it's quite, nobody likes that. So, risk of glaucoma is again, it's a irreversible loss of vision, and nothing can be done once the vision is lost. Now, most importantly, the risk of macular myopathy and detachment, which is almost 40 times more per diopter. As you see, from -1 to -3, it is 2 times, 2.2 times, 3 to 5, it is 9 times, 5 to 6, it is 40 times, and 7 to above is 126. That means a person or a child who has -7 is definitely going to get macular myopathy or retinal detachment. That's why we have to be careful. So it is so severe that vision loss, which is irreversible vision loss in many cases, can be compared with the smoking and hypertension and associated with the cardiovascular diseases. So in India, at least, there is a warning sign on the cigarette packs that it is, dangerous to health. But there is nothing written on the spectacles yet. But we should understand as a eye care professionals that the risk associated with single vision glasses and the importance of doing some kind of myopia control program for your patients. So I have tried to divide it into simple things. So too much indoor time, continuous close work, and single vision glasses, you are pushing the child into myopic progression. If the child has one parent myopic, then definitely there is a genetical factor which is again going to push that child into myopia progression. And if both parents are myopic, definitely child is going to become myopic. So I have created a little small, slope here with a card. If it is, just a child with normal parents, but doing a lot of close work, continuous close work, and you are giving him a single vision glass, there is a chance that child may go up to -3 diopters. It is not fixed, but this is what generally can happen statistically saying. So if there is one parent who's myopic, there is a chance that the myopia can progress up to -3 to -5 if you don't intervene. If you don't do anything, if you just give them glasses, single vision glasses, this is what is going to happen. And if both parents are myopic, there is a chance that child may become high myopic and go into serious complications. So as I said, 40% higher risk of comorbidity with every diopter increase. And so you have to start thinking of myopia management even if the child is at the 4 age and is not hyperopic, if it is emmetropic. So that means the child is going to become myopic. So coming back to how to control, how to do the intervention in progression. So you have to create a myopic defocus at the peripheral retina by whatever mean, by spectacles, by contact lenses, or orthokeratology, so that you can control the axial length of the child. So first choice what we have is a multifocal spectacles or bifocal spectacles. Executive bifocal were uh, easily available, progressive additional lenses are available. But with that, what happens is only in one direction, only uh, superior retina will get myopic defocus, inferior retina will not get myopic defocus. So there are a lot of other companies who did a lot of research, and this is the side glass vision, one of the companies who got FDA approval also for their design, and soon those glasses will be available in the market, which has a 360-degree defocus. Of course, they have not given out their design yet, but with understanding what we have is going to cause a defocus on the peripheral retina. They have done a lot of studies and they got encouraging results like 74% reduction in myopia progression in just 12 months with this kind of spectacles. Second, what we have is a multifocal soft contact lens. So center distance design. So in the center, the focus is on the retina, fovea, and at the periphery, there is a plus power which causes myopic defocus at the peripheral retina, sending the signal to the brain that stop progression. There is another company from US, MySight, which got a FDA approval recently. They have four optics design, and they also shows quite good control over myopia progression. So they are available in daily disposable lenses. It's by Cooper Vision. I have no financial interest in any of this. Then in India, in 2018, this multifocal soft contact lens was launched by Laser, and this has +3 diopters of progression. It's available from minus zero point 0.5 to minus 12 diopters. It is again a center clear, center distance design, and it's available in daily, weekly, and monthly disposable. The third option that we have is orthokeratology, which is most successful as of now. The most important of orthokeratology is this treatment is done in front of the parent when the child is in home. So the parents have full control over the treatment. It is just like orthodontistry. Of course, as a practitioners, you need to have extra instruments like topographer. Of course, you have to find refraction K1, K2. I'm not going to go detail into this. Dr. Matt is going to cover the whole topic of, I think Nitesh is going to cover the whole topic of ortho-K. And it is the fantastic treatment available as of now, which you can correct up to -8 diopters with a cylinder of -3 with a toric designs. And of course, we have low dose atropine, which is shown definite control over the myopia progression in children. They started with 1%, but now it is shown that 0.01% also works as effective as any other concentration. In India, we are fortunate to have this Mitro eye drops from Entod. In the US, they conducted one study. They tried different concentration, and one of the sample study showed that 0.025 is most effective. But of course, since we have 0.01, you can put 2 times and you get the same concentration. In case if you are worried, if you know that the progression is definitely going to go higher, both parents are myopic, child is spending more time indoors and all, then you should start a combined therapy, that is atropine as well as some kind of dual focus device like soft contact lenses, multifocal soft lenses, or orthokeratology. So you have to aggressively control the myopia progression so that their future can be saved, or you can control their comorbidities. There is one website. There are two websites which are available free called Myopia Calculator. You can punch in the age of the child, power of the at that time, and you can understand estimate that at and green vegetables, and you can check with vitamin D if they're spending more time outdoors or not. So this is just one pager that I created to emphasize on the myopia progression risk factors: no spectacles, single spectacles, contact lenses, single parent with myopic, and both parents myopic. There are a lot of websites available for learning more into detail of how to manage myopia. These are the links, these are my references. Thank you very much for listening. So we have next speaker. I'll request Dr. Bruce.
Okay, can you hear me?
Loud and clear.
All right. Let me share my screen.
So on a top, sir, there will be a red button that is a stop sharing. So you can stop sharing from there.
Do you see my screen now?
No, Chavan has to stop screen share first.
Yes, that is what I'm trying, but I'm not getting any.
Go to the share
Sir,
content.
on a top, you will be able to see the red stop sharing.
Yes.
The red button.
Okay. Bruce, go ahead.
Bruce, go ahead.
Okay. You see it now?
Yes.
Perfect.
Yep, it's on.
All right. All right. You know it's like 6 o'clock in the morning here in Seattle, right? So, but luckily I had some biryani last night, so my body thinks I'm in Hyderabad. So after this, I'm going to go home, brush my teeth, and go to bed. But anyway, we're going to talk about some soft multifocal contact lenses today. There are two studies that I think are significant. One was with, like Chandrasekhar said, with the MySight, and the other one was with the natural view contact lenses, which are a extended depth of focus. That means that there's a central distance, and then as you move away from the center, the plus power increases significantly. And as was discussed before, it puts that hyperopic focus in front of the retina rather than behind the retina. It doesn't stimulate the retina to increase in length. This is some of the options that we have available for controlling myopia. The first one listed here is orthokeratology. Then there's multifocal contacts, atropine, spectacles, and atropine. And we can see that orthokeratology, it's difficult to measure the refractive change over time because of the effect of the orthokeratology lenses while you're wearing them, and patients don't like to stop and remeasure their refractive errors. So, but we can measure the axial length, and we can see that orthokeratology and multifocals are roughly 40% reduction in the rate of change. The perinzapine, which hasn't been available, may be available soon, multifocal spectacles. There's a couple of new studies on the multifocal spectacles that show better results, but we don't have those. I don't have those results at this point. And the 0.01 atropine is incredibly good at slowing the progression of the refractive error, but not very good at halting the axial length progression. So this is just a kind of a compilation of all this, of a lot of studies that have been done, and you can see here by this graph that are on par for controlling the refractive error, and atropine is obviously at the top. But then again, I worry about axial elongation. I don't know that it's more important to control the refractive error than it is to control the axial elongation. That's the thing that I feel causes the problems that Dr. Chawan had talked about earlier, where you get the maculopathies and the cataracts and the glaucoma and all of the things that are associated with higher myopia. So this is from the MySight study, and you can see that from this chart that the people on the control lens, which was just a daily wear disposable single vision contact lens, progressed pretty rapidly, and the people on the MySight had a much slower rate of progression at 36 months or 3 years. And then if we look at 4 years, at the end of 3 years, they switched the single vision lenses over to the MySight lenses, and you can see the dramatic change in the progression of the refractive error. And here again, if we look over here, this is the axial length determination. And here again, the axial length was progressing very rapidly with the single vision lenses, but slowed significantly with the myosite. And then again switched at 36 months. And you can see the difference in the rate of change of the single vision lenses as compared to the myosite lenses. So a pretty significant difference there. And there it is at 60 months. So the overall change in the spherical equivalent or spherical refraction was 59%. And the important thing was that the average change in the rate of progression of the axillary elongation was down to 52%. This is a huge difference clinically in that it's going to keep these kids from getting up into the -5, -6, depending on how soon we get them, of course. But if they're at -1, -2, -3, -4, we can really slow that progression and save those eyes in the long run. And this is the basic design of the lens. It has a central distance area, then it has an adjacent, what they call a treatment zone, which brings that hyperopic focus back inside the retina and takes the stimulus away from elongation of the eye. Then it has another correction zone, which focuses the light on the retina, of course, on the macula, and then finally peripheral treatment zone as well that brings that focus inside the retina. These are pretty standard, the things that we do on a normal basis. If you've got a kid in a myopia management program, you're going to do all of these things. You're going to do an initial comprehensive exam, and if you're going to be serious about myopia management, we need to measure that axial length in the initial exam or in the myopia consultation when you bring the patient back and decide what kind of treatment you're going to put them in. And then we do obviously a 1 week and a 1 month follow-up. We can assess those. And then a 6 month follow-up is important too. And normally I will do biometry again at 6 months. And then after that, the annual exam, of course, which includes just about everything. And then a 6 month follow-up after that, just to measure that refraction, check the corneas, make sure that we're not progressing. If we are, sometimes we'll add atropine or something else to try to enhance the reduction of the progression. So selection of those. This is important because you're going to get to refraction. You can do the best you can on the refraction, calculate the required lens, then do an over refraction and see if we need to change it up or down or whatever to give them the best corrected vision. When they come in for their 1 week or 3 month or 6 month or whatever follow-up, we're going to also do another over refraction, and sometimes it'll show, or if it shows a little bit of progression, you want to be careful. As you saw from that chart earlier, that single vision correction actually, undercorrection actually increases the rate of myopia progression. So we want to stay away from overcorrecting these people and putting them into, plus 50 or plus 75. We want to keep them right at about 0. So unless you can get an increase of like 3 letters on the whatever line you've achieved with these lenses, a quarter diopter at a time, you just don't want to try to add too much because we don't want to overcorrect these these patients. These are just the parameters of the lens. Would have been nice if they'd have. I do a lot of kids, so 14.2 lens is pretty large. If we could have gotten a 13.8 or something, might have been a little easier for handling. But most of them pick it up pretty well. No real problems there. The next one I want to talk about is the natural view extended depth of focus lens. This design is, I think, similar to the laser or whatever you have in India, but it has a central distance and then it increases plus significantly as it moves toward the periphery and brings that peripheral retinal focus way inside of the retina and reduces the stimulation for increased axial length. This study was done. There were 32 subjects. The children kind of served as their own historical control. They initially baseline. They measured the age, of refraction, the type of correction they used, calculated the dioptric progression per month since the last annual exam, and then they annualized that data. Then they fit them with the extended depth of focus lenses and spectral refraction, obviously, and calculated the progression per month from the last exam. Demographics: 36% male, 64% female. Age was about 11 years old average, range from 6 to 19. And the duration of wear was about 11 months and went from 6 to 25. And you can see a dramatic reduction in the rate of myopia progression with these lenses. It's just an incredible finding. Multifocal, 96% of the kids that use these lenses reduced their rate of progression. And you can see here that 81% showed no refractive error change or showed a decrease in refractive error. And that is huge for these kids. This chart is amazing because it shows all of the data that they took prior to fitting with the lenses. They annualized it over a period of time, and you can see how just about every one of the 32 subjects were increasing in myopia and axial length. And as soon as they fit the lens, you can see how that curve bends. And even in the lower myopes, the 1s and 2s, you can see how it actually reversed the refractive change. And then if we look at the axial length, same thing. If you look at that one that's maybe 5 from the bottom, look at that rate of change, and then once the lens was fit, that bends completely back up, and it looks like it just totally stops it. So I do mostly orthokeratology. I do have some kids that either refuse to wear the lens at night, or they're not adult enough, I guess you would say, to manage the lenses properly, or they're just skipping nights and they're progressing. And so we'll switch some of those kids over to a daily wear disposable soft lens that mom can put in the morning before they go to school. I like the Ortho-K because it frees the kid during the day of if they want to go swimming or playing in a dusty field or whatever. There are fewer complications than you have with daily wear soft lenses. So I use these in a situation where I can't convince or can't get the kid. Sometimes even on the higher myopes, like the 6, 7, 8s, we can't get a good enough refraction, and they would neither need to wear either a contact or glasses during the day. Some of those I'll put into these multifocal contact lenses just to get them over the hump. And so that is how I use those. If you want to contact me, there's my email address. I'm available for answering questions anytime, any place. So I'm going to turn it back over to
Chavan.
Oh, wonderful. Thank you, Bruce. It was great. You have given us the first-hand experience of the new designs that has been FDA approved after so many years of this proven data. Thank you very much.
welcome.
We'll take the questions at the end of the session. So now I'll invite Nitesh to give his presentation. Nitesh, you have to unmute.
Yep, I'm coming on. Don't worry.
Okay.
Sorry about that. Yep. Is my screen on?
Yeah, you're fine now.
You are doing well.
Thank you. Now, obviously, Dr. K. Mehta explained about orthokeratology. Shekhar went through it a little bit. So I'm just going to go through it in a slightly different way. As you know, orthokeratology has had a lot of research done on it. And I'll just define it slightly just to say what orthokeratology is. Ortho-K lenses work by altering the corneal shape from prolate to oblate, resulting in a reduction in central corneal curvature. The alteration of the shape is a result of the flat lens design, causing a redistribution of corneal epithelium and anterior stromal tissue over the central treatment zone, which is 5 to 6 millimeters in diameter. The central treatment zone is dictated by the pupil size and treatment zone. What I need to emphasize here or point out to you that orthokeratology originally was a modality, just to an alternative modality for correcting myopia. So instead of wearing spectacles or contact lenses, you went on orthokeratology, wore it overnight, and got a myopia correction. So that was the first aim of orthokeratology. And there, as I said, I've mentioned so many studies that have been done. There's about 43, I think Bruce mentioned on his site. But there was a 12-year-old effects of orthokeratology and myopia progression, 12-year-old study, which again shows how Ortho-K has been successful in what it has been doing. And it is 36 to 56% at the moment effective on myopia control. Orthokeratology also is compatible with atropine controlling myopia. And as we know, Bruce talked about multifocal. So again, there are other modalities you can use to control myopia. But in the study, this which I'm just pointing out is that Ortho-K lens is mildly better than atropine in controlling axial length elongation and myopia progression. Besides, OK lens users do not suffer photophobia and risk of inducing crowding of anterior chamber angle and increasing intraocular pressure, which may be induced by atropine. Moreover, the benefit of OK lens include the ceasing of wearing glasses in daily life, which brings convenience, better quality of life. So orthokeratology, when patients are asked after they've been on it, they do like the quality of life with orthokeratology. Now the safety is one of the factors which we have to look at because it's a nighttime wear lens. And Mark Berlimer's safety studies, again, microbial keratitis in 30-day accident wear silicone lenses whereas to be 14.4% per 10,000 persons of wear. And again, similar results was with orthokeratology. So safety-wise, again, orthokeratology is very, very safe. Now, simple Ortho-K was giving us superior results, as we know it from all the studies done. But can we now make it even more better? So let's look at if we can do a lens that is more better for myopia control to give us even better correction. As you know, what we need in a myopia control design, what we need is a peripheral hyperopic defocus can halt the progression of myopia. Traditional orthocare designs can help with myopia control, but they were originally designed for myopia reduction. I'm repeating this again. Orthocare for myopia reduction, temporary reduction of myopia associated with corneal flattening. Orthocare for myopia control, reducing myopia and stop the increase in the axial length of the eye. That should be our aim with orthocare now. Now, myopic defocus is to get on the retina, so we actually flatten the cornea and see clearly by removing the myopia. Hyperopic defocus is the other part we have to look at. Lorick study determined if orthocare is effective for myopia control. Another study with a 2-year study. Axial length, vitreous chamber diameter, and changes in children undergoing orthocare treatment. Compare the orthocare rates of change with children wearing single vision spectacles. And this is what it was showing, actual growth results, vitreous chamber depth in a 2-year period or 24 months. And you can see here, orthocare and control groups, there's a significant difference in control of axial length after 24 months. Eye elongation, again, you can see axial length and vitreous chamber depth. Again, a massive difference in 24 months. Control was 0.48 in 2 years. Orthocare was 0.23 in 2 years. Orthocare twice as good in every category. Again, myopia control mechanism, pre-OK prolate cornea, the foveal blur area. The normal aspheric cornea provides almost no blur on the fovea. Orthocare provides the blur. Myopia control designs can be labeled as pediatric orthocare. Traditional designs can be labeled as adult orthocare, as large optic zones are needed to reduce the chance of any glare or flare. Myopia control orthocare is best for children and adolescents who don't yet drive. Once the patient is of driving age, if they experience glare or flare, they should be refitted in a larger optical zone designs. Myopia control orthocare, best to start early when patient is -1. I'm starting at -50 now. Best chance to hold patient at plano throughout adulthood. Typically, if a patient starts orthocare at -4, then -4 will be their baseline. The idea of myopia control is to halt the progression, not reverse the progression that has occurred. Traditional orthocare, larger optic zones, spherical optic zone, and single reverse zones. Myopia control orthocare now, smaller optic zone, aspheric optic zone, and double reverse zones. Traditional orthocare, standard 6 mm optic zone, too large for defocus. Spherical radius in optic zone does not create multifocal effect on the post-orthocare central cornea. While the reverse zone is optical, it is too far outside the field of vision to create peripheral defocus. Myopia control orthocare, a spheric optic zone creates multifocal effect. Reverse zone 1 creates +4 hyperopic blur. We need minimum of +4 in order to get that hyperopic defocus. Smaller optic zones allow wider alignment curves for better centered lenses. Here I've got to point out, in the old days we didn't have the technology to do all this. So what we used to do with traditional orthocare was increase the Jessen factor to give you that effect. Aspheric treatment zones create a multifocal effect on the post-OK cornea that causes a desired peripheral defocus. The myopia control lens should fit like a normal reverse geometry lens, but with a smaller treatment zone. Myopia control lens optic zone should be 2 to 5 mm central bearing. Return zone 1 should be 0.4 to 0.6 mm brilliant pooling. Return zone 2 should be 0.4 to 0.6 mm pooling. Alignment zone 1 mm wide dark alignment. Alignment zone 2 0.6 to 1 wide light alignment. Narrow but brilliant edge lift. Determining the optic zone diameter, you need to measure the pupil diameter. And the optical zone diameter should be plus or minus 0.2 mm than the pupil. 5.4 mm is found to be best in the Caucasian population, but I believe we can, in Indian population, is not too far either. and the female would be 5.4 average. So myopia control post-wear topography, we see smaller treatment zones, deeper reverse zone rings, wider, flatter alignment zone rings. Orthocare in general is a safe option for myopia correction and retardation. However, the long-term success of the treatment depends on a combination of multiple factors, including proper fitting of the lenses, rigorous compliance to lens use and care regime, adherence to routine follow-ups, and timely and appropriate treatments to complications. I'd like to thank you for inviting me to speak here. I've just done a quick talk because I was told it's 10 minutes talk. So that's what I've tried to sum up with the Orthocare with myopia control Orthocare lens together. Thank you for listening.
Thank you, Ditesh. Thank you. It was really great, wonderful. You covered everything in 10 minutes, all the most important points. Thank you, I appreciate it.
Thank you.
So let's get Matthew Martin. As we know, all of us are in lockdown. We are not seeing many, whereas busy with the patients. So he has on how to manage this COVID and post-COVID situations, and we want a lot of tips from him and any inputs on post-COVID situations, especially on how to handle the patients, as well as how lenses to be stored or handled by the patients in this post-COVID situation. Dr. Martin.
All right. Good morning. Can everyone hear me okay?
Yeah. Jawan, you need to stop your screen. Yeah, fine.
Outstanding. So you can see my screen, is that correct?
Perfect, Matt.
Excellent. So today I'm going to be talking about something that you guys are going to be facing in your future if you have not started thinking about this already. So there's going to be some talk in here about Ortho-K patients, but I really also want to give you a good start on some overall things that you're going to need for your entire office in a post-COVID-19 situation. So just be aware that I'll be talking about Ortho-K within the context of seeing patients in the office. So as you may have gleaned from some things earlier, I am actually in process of seeing patients today. So right now I've got a very short break. My staff has been holding patients for me, so we're going to go for this. I'm hoping that you will enjoy what I have to say. There's some really interesting things here. So I think it's important for us to start thinking about what we're going to do when you guys get back open. So I think you really need to consider changing the entire flow of your office, because it's going to be a brave new world. So the first thing that we did at our office was we brought staff in with a closed office, and we started in a very methodology-oriented, methodical manner to look at the things that we wanted to do in order to best serve our patients and our staff. So the first thing that I'm going to suggest you consider doing is beginning by going on a walkthrough. We started at the front of the practice. We moved from intake on a patient, every small step, and we mapped out the touch points, places where patients are going to interact with us, places where they're going to interact with objects. And from that, we considered social distancing, how to keep patients so that they are being seen, but that they are not causing harm for themselves or for the staff. So our first priority was to protect the staff. Without the staff, certainly we're not going to be able to continue practicing. But we also want to protect our patients, because we don't want our patients to end up in a situation where they're going to end up sick from coming to our office. Then we said to ourselves, geez, what an opportunity for us to streamline our procedures and to become a better, stronger office from this experience. So one of the things I really want to remind you is it's all about clean, clean, clean. Like, we were a clean office before, but wow, we're really setting the bar high now. And then you need to be ready to change, because just when you think you've got everything ironed out, actually seeing patients changes the things that you thought they weren't going to be interacting with, the things that maybe need to be done differently. So the first thing that we're doing at our office is we're sending out a pre-clinic letter. So every patient that comes into our office receives a letter in the mail from us, and that letter explains to them the rules of the office. And it tells them the things they need to be aware of before they even come in. So we're asking them things like, are you running a fever? Do you have shortness of breath? Do you have a lack of taste and smell? Do you have body aches? We want to know ahead of time whether they're showing these symptoms, so that when they come into our office, we can tell them to come in or not to come in. And every single patient knows that when they come in, it's a single patient. It's not 5 people. It's not 1 woman and 3 children, or 1 man and 2 kids, or 4 family members. We want it set up so that it's a single patient and 1 caregiver if someone needs special needs. Now later on, we may relax these restrictions 3 months, 6 months, a year down the line. But for now, we need to be thinking about these things ahead of time. So what are the rules of our office? That's a great question. Patients must wear a mask in our office. The staff must wear masks. As anyone who's seen me lecture, I'm a big fan of fun shirts and flamboyant ties, but I'm wearing scrubs now, which I'm not terribly thrilled with, but which have allowed me to wear my scrubs at the office and then go home and wash them immediately. The entire staff washes their scrubs daily. The staff has their temperature taken every day as well. And then this is really interesting. There's N95 masks were very difficult to find. So here in the United States, people have been making their own masks. What I think is exciting is this mask design. If you look at the bottom left-hand side of the slide, you'll see a mask design that one of my staff members found online. What's cool about it is how high it comes on the bridge and the way the sides are done. If you look at the nose, it actually fits underneath your glasses. And by fitting underneath your glasses and the way it's designed, it actually vents the air out the sides, which is very important for those of us who wear glasses. So many of my patients come in with complaints that their glasses are fogging. It's very hard to do a slit lamp examination when you can't see anything. But this mask design solves that. And you can look for patterns like that online if you have a staff member that makes them, which is what happens in my office, or if you're purchasing from someone. If the patient's wearing a mask, a cloth mask, and I'm wearing a cloth mask, the safety and efficacy is quite excellent. In our office, we have a very limited schedule right now. We're seeing patients by appointment only, and we actually are keeping the door locked. That's a strange thing to have happen, because in my office, we have a very small footprint. We see a lot of patients, so it's a new methodology for us. We're very upfront with our patients. We tell them, you must come in for your appointment, because no-shows right now are very difficult to fill in. In our reception area, we've changed the way we've done things. We've gone to a single pen when they check in so that we can clean that pen afterwards. We have gone virtually paperless. Traditionally, we've had a deck sheet that follows the patient around the office. We've done away from that completely. If a patient hands us their credit card for payment, we wipe the card, scan it, do the things we need to do, wipe the card, and hand it back to them. Very strenuous cleaning needs to be applied to your office in order to make sure that staff members don't end up sick, or the doctor doesn't end up sick, and the patients also need to stay healthy. We have special appointment slots we've set up for senior patients. In the morning when the office is maximally cleaned, and then at lunchtime we clean for 45 minutes before we go to lunch, and then right after lunch we have appointment slots for seniors as well. We reconfigured our reception area for social distancing. You'll notice in the picture here on the left that we have a single chair here, and there's a single chair under, roughly speaking, where the camera would be taking the picture from. We moved a dispensing desk to the reception area so that we can do dispensing where patients don't come fully into the office, which I thought was really exciting. So the standing reception, or the standing dispensing desk, is pretty slick. The chairs are separated, as you can see, and this is neat. We put stand here signs in so that when patients come in, they can see where to stand for their social distancing. We had to eliminate our kids area because as an Ortho-K and myopia control office, we have a very strong child pediatric population here, but we actually had to eliminate that because we can't have tons of kids running around the practice touching walls and spreading germs around. So we actually had to limit our play area. We compensate for that by making sure that we run a very tight schedule and children don't sit around. We also brought in plexiglass to protect our reception area, which was pretty easy to make. I purchased that and put that together in about 20 minutes, very straightforward. And then we also have extra masks here at the office, so when patients come in, if they don't have a mask, we don't even let them in the office. We make them wear a mask before they can come in and be seen. So we've also had some technician precautions that we put in contact as well. So we have limited contact with patients and staff. We eliminated the deck sheet so that there's less paperwork to carry germs around. We switched to a hands-free tonometer system in the office, which actually has been working really great for the children. I love that. And then everyone gets their temperature taken. The staff gets their temperature taken, and each and every patient gets their temperature taken. If they have a high temperature, they're out the door, and we reschedule them for another visit. Also, obviously, we've always been into hand washing, but now we're really emphasizing with our staff. Hand washing, hand washing, hand washing between each and every interaction. If you're at a sink, it's a hand wash at a sink. If not, it's instant hand soap. Obviously, my staff is wearing masks, and then we've thoroughly cleaned the room. We're cleaning rooms now on a level that we used to only have when we had potential infectious patients in. Now we're cleaning routinely at just such a high level. Now let's talk about Ortho-K specific stuff. In our area of the country, or in our country in the US, we're hydrogen peroxide based as far as cleaning is concerned. And obviously, if you're an Ortho-K patient during this time, we want to make sure that you're getting the cleanest possible Ortho-K molds or lenses. And so we're making sure that they really understand the concept of hydrogen peroxide and making sure that things are clean for them. I'm a big trial fitter, so traditionally I fit a lot of trial lenses, Ortho-K trial lenses. So a patient comes in, I fit them out of my trial set, and those lenses are cleaned between patients, but right now we're doing virtually no trial fitting at all. And so we have to see where that's going to fit in for us going forward. We may be in a situation where we don't even feel comfortable fitting trial lenses on people, or if we do, that may be years down the road before we feel comfortable with that. So we're going to have to kind of feel out where that's going. Ortho-K specific education, we're trying to discourage people from using plungers for removal. Traditionally, I have been a plunger guy. We teach patients to take them out with a plunger. It's worked very well for me. The problem is it's hard to always get that plunger clean. So when patients are using a plunger now, we're really aggressively telling them you have to put that on hydrogen peroxide overnight. That has to be cleaned. And we're very much discouraging them from using that. We're re-emphasizing hand washing and overall cleanliness. A lot of patients get lazy. We really have to drive home. In the age of COVID-19, man, cleanliness is very, very important. We're talking more with them about rinsing their cases and making sure that they're disinfecting their lenses and storing them in a sealed container. And this is one that didn't really seem obvious to me until a patient did it. Don't let your patients wash their hands with hand sanitizer and try to put their retainers or their Ortho-K lenses in, or it hurts. I would not recommend that. So be sure you talk to them about that as well. Now, here in the States, we've seen a link between COVID-19 and viral keratitis. As a matter of fact, when this first hit in our area and shut us down, I had an Ortho-K patient who came in with a very severe viral keratitis. My Ortho-K patient worked in a hospital environment where he was greeting people at the door and triaging without a mask, okay? This is when the first thing hit. I am not sure, but I am highly probable that my patient had a COVID-19 keratitis, okay? We treated him as if he was an active COVID-19 patient. extreme measures. I was the only one in the office. We cleaned the room to an incredible degree afterwards. But you need to really reinforce to your patients any redness, any pain, any photophobia, any decrease in vision, boom, they got to get a hold of you right away. Moving away from Ortho-K and talking a little bit about dispensing desks, if you're an office that has glasses, you need to be taking some special precautions there as well. We have separated our dispensing desks so they're more than 6 feet apart. Our limited schedule is allowing us to see 1 patient at a time right now, or 2 patients maximum, but they're spread by distance, okay? Everything gets cleaned incredibly thoroughly between patients. The staff is masked. Patients are masked. We're wiping chairs. We're wiping keyboards. We're wiping everything down, which brings me to frame cleaning. One of the questions that we ran into is, yes, we do Ortho-K, but also we do glasses because a lot of offices have to have both of those 2 components. One sometimes feeds the other. So we looked at different methodologies for disinfecting frames. We looked at UV. We looked at hydrogen peroxide. We looked at bleach. We looked at special cleaners. We finally settled on a very simple tactic, and that is warm water, Dawn dish soap, and scrubbing the heck out of our frames. A lot of doctors have asked me, how can you do this? How can you wash frames without ruining the frame tags? And the answer for that is that our frame pricing is by frame line, not individual frame, so it allows us to do that without it causing a problem. We now know that UV, if it's used often enough, can cause problems with frames. Hydrogen peroxide can break down metals. This seems to work the best method for us. They do a frame selection, the frames get put into a tray, right to the back room and get cleaned. I know I covered a lot of things here, but I need you to start thinking about your practices are going to be opening not too far from now. What things will you be doing differently than what you're doing right now? And I want you to remember, at least here in the United States, things are very political. There's a lot of very angry people associated with this whole thing. I would like everyone to be kind to one another. If you need to reach me, I can be reached at auburnoptical@gmail.com. Thank you.
Wonderful. Thank you, Matt. It's really nice. You have elaborated everything, and hopefully all our doubts are clear now and how you're managing. Of course, I'm going to take the questions afterwards. So let us see. Our next speaker is Dr. Quresh Maskati, who will be speaking on low-dose atropine, which is very popular amongst ophthalmologists. And I welcome Dr. Quresh Maskati.
Thank you. Okay, my slides visible?
Yeah, Quresh, you're on.
Okay, so I'm going to talk about something which the ophthalmologists are very excited about since the last, as Keki mentioned, couple of years, the role of low-dose atropine for myopia control. In India, it's been a couple of years, but it's been around for about 2 decades now. Let's see how atropine started. Atropine is not a new drug which has suddenly been discovered. The history of atropine use, it was first used around the 1600s, but by the mid-1800s, atropine was frequently used in ophthalmology for pupil dilatation to examine the posterior segment of the eye, also as a temporary treatment to improve vision in cases of cataract. So if there's a central cataract, you dilated the pupil with atropine, and sufficient amount of light went around the cataract so patient could see, especially in children. It was also used to induce mydriasis during cataract surgery. So people discovered that if you had a dilated pupil, the cataract surgery was easier. In those days, there was intracapsular cataract extraction where the whole cataract with its lens capsules was removed. And it was found that it was very useful to prevent or to break the posterior synechia in cases of uveitis. As you can see in the picture, there is a patient where the synechia there, the pupil is stuck to the cataract, and you can break the synechia in the early stages by use of atropine. So atropine became popular from the mid-1800s, but nowhere was it used in myopia. Now, since the late 90s, 1990 onwards, people started taking an interest in myopia control using atropine. And Shi et al. Came out with a landmark paper in 1999 where they did 186 children with varying doses of atropine. So now at that time there was no fixed thing as what would work. So varying doses of atropine were used at 50% progression compared to those on tropicamide. So 50% of those could be stopped, the progression could be stopped with varying doses of atropine. They still didn't know which was good, but if you compared it with a control group which was on the simple tropicamide, the atropine seemed to work better. And then the landmark ATOM study, the first ATOM study called ATOM Study 1. ATOM stands for Atropine in the Treatment of Myopia by Chua et al. 2006 they published this. It was a randomized, double-blind, placebo-controlled trial, very big, including 400 children, initially over a 2-year period. So ATOM 1 was for a 2-year period, and it showed that 1% atropine, at that time it was just 1% atropine, 1 drop applied daily in the eye over a period of 2 years, reduced the progression of myopia by 77%. So it was fairly good. 77% progression of myopia was reduced, but 1% atropine was used at that time. So then how did we arrive at 0.01? After that study was done, several other percentages were tried. While a higher percentage like 0.5% was found to be very effective compared to placebo in a 2001 study, unfortunately children were dropping out because of the side effects, a lot of photophobia, a lot of other crowding of the angle and things like that. So it was effective, but there was dropout, which we didn't want. So then Wu et al. In 2011 studied a group of 117 children. 97 children received 0.05% or 0.1%, and 20 children were included as a control group. And the mean follow-up was huge. It was 4.5 years follow-up was done. And then the landmark ATOM 2 study came, which was in 2012. So it built on the ATOM 1 study. It used, again, 2 years like the ATOM 1 study. So the ATOM 2 initial was 2-year results. They used 0.01% atropine applied once at night, just a single drop at night. And they found that the results did not differ significantly from the 0.1 and 0.5% atropine solutions for control of myopia. But this had minimal side effects. So they came out with a great discovery that you don't have to go to 0.1 or 0.5%. You can go as low as 0.01%. So the dropout rate is minimal or zero. And because the side effects are not there. What did they find? Was it effective? Over 2 years, the mean progression was minus 0.3 diopters in the 0.5 group, minus 0.38 diopters in the 0.1% group, and minus 0.49 diopters in the 0.01% group. So though the higher percentages had a smaller increase in progression, the 0.01% didn't do too badly either, just a half diopter increase over 2 years. And all groups had progressively significant slower progression than the control group. You remember the control group, which was tropicamide group in ATOM 1. So all of them did much better than ATOM 1, which the control group was 1.2 diopters. So 1.2 diopters versus just a half diopter in the 0.01% group. Is there a rebound effect? So in the first year, control was best, as I said, with 0.5%, just 0.3% increase, 0.3 diopter increase. However, a cessation of treatment often resulted in a myopic rebound effect, which was more pronounced in eyes that received a higher percentage than those that received a lower percentage of atropine. So one more reason not to go for the higher percentage, not even 0.5%, is that the rebound effect is more on stoppage. So these results suggest that if you were, one possible approach would be for myopic children to use a more concentrated atropine solution of 0.5% during the first year so that you control it better, and switch to a 0.01% during the second year so that the rebound effect on stoppage is less. So that could be one possible solution. We're still playing around with this. In India, we have only the 0.01% to play with. So then what did they do? They continued the ATOM 2 study. Again, to repeat, the ATOM 2 study was for 2 years initially. So what they did was they did a washout period. So after receiving atropine at different concentrations for 24 months, that's a 2-year period, which was phase 1, there was a washout where the individual received no treatment for 12 months. So for the third year, there was no treatment given at all. None of the atropine drops were given. And then they saw how many of the children progressed by more than half diopter. If you progressed in the third year by more than half diopter, they were restarted on 0.01% therapy of atropine for a further 2 years. Why did they do this? Why did they choose 0.01%? Because previous studies have already shown you that atropine at 0.01% has the lowest rebound effect. So it was the most effective concentration to reduce the progression of myopia at 3 years and beyond. What is the analysis? Now, whenever there are multiple studies, you do what is called a meta-analysis. So meta-analysis in 2014 concluded that atropine could significantly slow myopia progression in children, and it showed a greater effect in Asian population than in the Caucasian children. So all these studies were done mainly in Singapore, Taiwan, Hong Kong, China, and the West, the US and the US FDA was very slow to adopt it. And they found that it was not as great in the white children, the Caucasian children, as in the Asian children. Another interesting meta-analysis by Wang et al. For interventions in myopia treatment, they chose 30 clinical trials and 5,422 eyes, and they found that 1% and 0.5% had slightly higher effects than the 0.01%. So what are the side effects therefore? The ATOM-2 study reported that upon restarting 0.01% atropine in children who showed progression after a 12-month atropine washout. So this is the phase 2 of the ATOM-2 study, where after 2 years there was a washout for a year, as I said. 192 patients were selected. What was the side effect of 0.01%? There was a mean increase in photopic pupil size of approximately 1 millimeter, a loss of accommodation of about 2 to 3 diopters. However, very few of these patients needed bifocal glasses for near, and the small percentage of pupil increase of 1 millimeter was not enough to cause photophobia or to get them to wear glares or anything like that. So though there was a little difference in the side effects were not significant enough to result in any dropout. So very small percentage experienced photophobia. So what is the probable mechanism of action of atropine? Really, the jury is out. We know that it is not related to accommodation. Previously, people thought that it's related to accommodation and reduced convergence, but it's conclusively proved that that's not so, because children with 0.01% are able to converge and they're able to read. And so it is possibly there is an anti-muscarinic action, helps in preventing the axial elongation of the globe. And as a previous speaker told you, funnily enough, atropine acts brilliantly in reducing the progression, but not that brilliantly in axial elongation. Ortho-K gives you a much greater prevention or reduction in axial elongation than atropine does. But atropine seems to be more effective than any contact lenses. Without having too much, it does reduce the axial elongation, but not as great as some of the other treatment mechanisms. So how long should you be putting atropine? Atropine, once started, should be used at least for 2 years, as the maximum effect appears in the second year. So in the first 6 months, sometimes you may not get this effect, great effect. So now I'm talking about some of the Indian experiences. Which children should be offered this therapy? Ramesh Kekonia of the LV Prasad, which has a good volume numbers, they started using this for kids over 5 years of age, with a documented increase of at least half diopter of myopia in the past 1 year or less. Even if in 6 months' time the patient has had a half diopter myopia, or after 1 year he's had a half diopter increase of myopia, and the child is over 5 years, you discuss the pros and cons thoroughly with the parents, explain that the side effects are minimum, and you need to get the parents to be cooperative. They must put the drops, 1 drop in each eye at night before the child sleeps. What are the patients whom you should not offer this? You should exclude children with anisometropia, astigmatism more than 1.5 diopters. Why do you exclude this? Because the ATOM-2 study excluded it. See, the ATOM-2 did not take children with more than 1.5 diopters astigmatism. We don't know how these children will behave. So till we know more and till we learn more, many studies are going on. It's wise not to take children with anisometropia and to avoid children with high astigmatism. then syndromic children with myopia, retinopathy of prematurity kids with myopia, because the mechanisms of myopia are different, and in myopic shift seen in patients who had pediatric cataract surgery. So you could avoid these till we know more about atropine and myopia control. What are the barriers to use of atropine? Why are not so many people using it? Even in the US, there are lots of people who are not using atropine. Some ophthalmologists, especially in the US and in India, are still waiting for long-term statistics, especially in India on the Indian population, because we got this 0.01% only since the last couple of years. We know that there are racial differences. We know that the Eastern Asian population does better than the Indian population, which does better than the Caucasian population. So people are still waiting for long-term results. Some parents that I talk to are not convinced, especially in low myopes, because I need to be honest. So I tell them that, look, your child has got -2 diopters. It may become -3 diopters after a year, but if I use the atropine, it might increase only to 2.5 diopters, because I tell them that the progression drops to about half, and it's 1.2 or so when you don't use atropine. So I'm quoting world statistics, and they say no big deal. If my child has to wear a 2.5 diopter spectacles or a 3 diopter spectacles, how does it matter? The thickness of the spectacle, doctor, is it going to be different? And I tell them no, it's not. So then they say there's really no motivation. The motivation is much more if I give them the myopia vision calculator and I tell them at the age of 18 your child may have -8 or -10. So then they get motivated. But then you need to spend more chair time with these parents and explain to them, because telling them that from 2.5 or 3 diopter the spectacle is not going to be changed in thickness. Many parents are more worried about the cosmetic effects on the thickness of the spectacles, on the glasses. So you need to show them the Brian Holden Vision Institute or the other myopia calculators and convince them about how using this is good for the long term and how the myopic macular changes and other things may be prevented. So there is a difference in different races. 0.01% is definitely better and prevents myopia progression up to 60% by Dr. Jitendra Jethani from India, who also has a large series compared to no intervention, so he is happy. We know from a meta-analysis that effects in Caucasians, to repeat again, is less than Asians. Pupillary dilatation can be up to 2 millimeters in blue eyes, that is in Caucasian eyes, up to about 1.5 millimeters in green eyes, but it's seldom more than 1 millimeter in our Indian brown eyes. So we are better off in side effects, and effect in the first 6 months is generally less. So you need to tell, when you call the patient after 6 months and the parents are a little disappointed, so you tell them right in the beginning that the second 6 months will be better than the first 6 months, and the second year will be better than the first year. So that's how you keep the patients with you. To summarize, 0.01% atropine is fairly safe for kids above 5 years of age. It should be continued for at least a couple of years. You may give a washout period of a year if the myopia is stable. And how long can you continue? You can continue till myopia stops progressing, even up to 18 years. Please understand that the atom studies were done up to a level of 12 years, but now newer studies are going on up to 18 years. Though there are no published studies for older children, there doesn't seem to be any strong side effect, so you can continue even up to 18 years or till myopia stops progressing. Thank you so much for your attention. Shawan?
Yes. Thank you very much, sir, for your in detail description about the atropine and how this treatment can be used. So I have a few questions from audience. I'll start with Bruce. This question is for Bruce. My sight lenses has universal base curve and diameter, or it can be customized?
Not to my knowledge. I think it is just one base curve, one diameter.
So it's a universal lens, basically.
Right.
Yeah. Then we have one question for Dr. Matt. Do you charge extra for these extra services that you offer?
I need you to repeat that for me, if you will.
Do you charge anything extra over and above your consultation fees for these extra efforts?
This is interesting. We have not done that yet. A lot of my colleagues are beginning that process. Certainly the dentists, the people working on teeth in our area have done that, charging extra for the PPE. And we may ultimately need to flirt with that. We charge a pretty premium price for our services already. And so right now we're absorbing that, but going long term, that may be something where we need to come up 5 or 10% on our fees going forward in order to pay for the extra time, energy, and personal protective equipment that it takes. So that's not off the table, but it's not something we're currently doing.
Right. Then we have questions for Dr. Nitesh Barod. So how is your experience with children's response to having to wear these contact lenses for myopia control?
I have been very fortunate. I've had no difficulty. In fact, in past we've had a couple of kids who were not ready to obviously put them in and take them out. Where we made an effort where one of my staff would actually visit their home and put it in for them. And within a week to 10 days, they would be okay and they would carry on. So realistically, no, children have never been a problem with fitting Ortho-K lenses. In fact, I find them better than soft lenses for some reason.
So you asked your patients to wear the lenses, or you asked the parents to put the lenses on?
We actually teach the parents, but sometimes the parents are not willing to put them in either, or the child will not allow it. Then one of my staff members will actually go in the evening to put them in the child's eye, and also in the morning take them out for them before they go to school. So it has been effective. It's only been 2 or 3, and I've been doing this for over 25 plus years now.
We don't have slavery in the U.S.
They get paid extra.
So there is one funny question here. Ortho-K lenses are for axial or corneal myopia?
How do you mean by axial? And axial is what we're going for, because the modality originally Ortho-K was to just correct the myopia. As Matt will say, we all did it for one thing and one thing only, to correct the myopia. There was no talk of myopia control. That came later on. And we've been doing this for decades. I think Matt and me did a fellowship together, I presume, on that.
So another question is for Dr. Maskati. This is, how much of myopia would you start your patients on atropine 0.1%?
I would love to start with lesser myopia, but it's difficult to convince parents. So what happens is, once there is I don't start on the first visit. So if a patient has myopia, say a -2 to start with, I would love to start atropine, but I normally tell them to come after 6 months. And I tell them we'll see the rate of progress. And if after 6 months, if the myopia has gone up by half a diopter or more, then I will start the patient on atropine therapy. So it's not the initial, but it's the progress. If the progress is more than half a diopter in 6 months' time, I will. And I start early, just like Kekunia said. I also start motivating at the age of 5 years.
Right. So I have another question for Dr. Bruce. Are the chances of infection due to contact lenses similar to other contact lenses? Or is there any extra risk with Ortho-K or soft contact lenses for children?
I don't think anyone's done any actual studies, but I think daily wears are certainly, or daily disposables are certainly safer than trying to sanitize and wear lenses more than once. And the is not significantly different in terms of curvatures and diameters and materials, so you wouldn't expect it to be any higher with a myopia control type multifocal contact lens than you would with any other kind of soft contact lens.
Okay, so we have one more question for Dr. Matt. A child comes in with the parents, both parents are myopic, but the child at the age of 6 is not showing any myopia, or he's normal. What will be your approach? Will you put him on anything, or you will take an extra efforts, or what?
So is the question for me,
Yeah.
Chandra?
Yeah.
Okay. So if the parents are myopic and the child has yet to become myopic, we would typically continue to monitor that child with axial length measurements if you have that available, and certainly with refraction and cyclorefraction, I tend to wait till the child begins some myopic shift, whether it's a half a diopter, as Natasha talked about, or as much as a full diopter, before we jump in there. That's my personal experience. I am leaning more and more towards getting in sooner. I think actually Natasha and Bruce may have a more aggressive plan than that, so I'm going to defer to them. But for right now, what we've done is wait for that child to show those first signs of that shift towards myopia. I do have some parents who are highly myopic whose kids never make that transition to myopia, so I hate to go too crazy with treatment for them ahead of the beginning of that process.
What is your take, Nitesh?
I would actually not go on any modality as such, but I would advise on what not to do. What Dr. K.K. Mehta earlier mentioned, where we need to look at the outdoor time, digital devices. All those factors should be put in as soon as possible. We are doing what we call hygiene also. You know, we need to talk about vision hygiene now. So if there is no symptoms or anything else, why not put that into the procedure? Tell them that, advise them that, get that into the process, the ball rolling. And if it still changes, then yes, we can move in aggressively and deal with it.
Yeah, we do that as well. I think Natasha's 100% right. Whenever we have strongly nearsighted parents, we're always advising children, you know, keep that laptop a distance, keep that tablet away from you. Let's get you out of the house. That is 100% true. Along with nutrition, do you factor nutrition into that, Natasha?
Become a convert on nutrition now. So nutrition is one of the things I now to talk about a lot more because of macular degeneration, which I've also got involved in, and myopia. So both are interrelated with maculopathy. So if we can do some nutritional advice early on, they could save other possible problems occurring later in life too. So why not? We are in the front line.
Bruce, do you have anything to add?
Well, I might be a little more aggressive. You know, if I've got a kid who is at high risk due to all the factors of parents and lifestyle and everything, we counsel them on lifestyle, just as anyone would. And I try to see them on a 6-month basis. And if I see you know, a 4 or a 5 or a 6-year-old kid, when I first see him as a -1, and 6 months later he's a -75 or a +1, and 6 months later he's a +75, and 6 months later he's a +50, and he's 6, 7, 8 years old, I try to advise the parent that this kid is probably going to become myopic, and we should either start some kind of myopia control now before it happens, because it's a lot easier for me to prevent it from happening than reverse the effect once they get into myopia.
Dr. K.K. Mehta, you have seen so many children, and I guess you already started atropine treatment for the kids. What is your opinion on that? If both parents are myopic, the child is yet to develop myopia, would you start them on atropine or something, some preventive therapy?
Well, not unless they are already showing signs of myopia. But what surprises me is no one here has spoken on something which I thought was clearly understood, that you have to cut down near point activity after 9 o'clock at night. That means the child does not use a mobile. He doesn't use any of his activities which require convergence. If you cut it down and tell him after 9:30 at night, you can watch TV, you cannot read. If you have a lot of reading to do, you do it early morning, not late night. You will find that the effect of the atropine is significantly improved. We have had patients who have been on atropine and they come 4 months, 6 months later with an increase. The first thing you ask, what were you doing at night? You were reading at night. And they say, yes, there was too much homework. So there is a direct causal relationship. I haven't seen any references, but from my experience, I can say that is true.
Yes, Dr.
Jackie, I'd like to add that even before atropine came in my practice since the last 30-35 years, I've been telling kids not to read at night, that they must wake up in the morning on what we call, it's easy to convince the parents. You use the terms that read in the morning if you have exams or something on fresh eyes. when your eyes are fresh and can do the work for you, rather than late at night when your eyes have been used throughout the day and you're flogging a tired horse. So that's the example I use even before atropine came in, that you need to, as Keki rightly said, stop doing their study work at night and do it on early morning, and it seemed to help. Atropine just, when it came in, it just added on. But Keki, one question which parents always ask me, they want to quantify by numbers. How many hours in a day can my child use a gadget? And I have really no answer for this. They say if I have 6 hours, and can I split it into half-hour segments, something like that. So how do you quantify this?
You see, basically, I don't believe it really requires quantification. A child's convergence ability is quite a bit. A child can read comfortably in a single lamp, in a single candle, while an adult after some time will have a problem. But I've advised them that if you utilize it for any period of time, after 15 or 20 minutes, put it down on the table, go for a walk, spin around and then come back again. Because once you break the attachment of the child to his handheld appliance, usually he changes his mind and goes elsewhere.
Yeah, what I tell them also is that the smaller the gadget, the worse it is. So TV is the best, and followed by a desktop, laptop, iPad, and then your mobile phone is the worst. So,
as a matter of fact, a lot of the schools are now recommending that if the child is to use an iPad, it should be a larger size iPad and not a smaller one, because the size gives you a better definition and there's less strain onto the eyes. But a very quick, but just to break in between, you know, if you explain to the parents that studying at night is not a question of studying, it's a question of how much you can reproduce. I explained to them like a Godrej filing cabinet. They call it a filing cabinet and they call it as a file retrieval system. You can file anything, can you find it? So if you study in the morning, your retrieval system is better. You put it that way, the parents will automatically make sure the child studies in the morning and not at night.
Great.
Because now, post-COVID situation, most of the schools are advising to study from home.
Correct.
And the screen time is already increased. Yeah, Dr. Matt has to go. Thank you, thank you, Dr. Matt. It was really wonderful interacting with you. Thank you. I will let you go. We'll just continue the discussion here. The future is like more on a screen. As Dr. Keki Mehta said, that bigger screen is better. So maybe screening on the main TV from your mobile phone or something can be advised, or any other practical tips that you would like to give. Dr. Maskati.
Yes, it's a great idea. But you see, some of the parents are not as tech savvy as the kids are. So the simple thing of connecting your mobile to the TV so that you can see things on a larger screen, if it can be done, it's great. Even the schools need to be told, because some of them are just bunching their education without a break. It was all right when they were in a classroom, but here when everything is on a screen, 2-3 hours of continuous study work is done on the screen. So the school teachers need to be told to give the kids who are sitting at home a break, as Keki says, after every half an hour, give them a 5-minute break or so, and then let them come back to the next class.
Yes, Dr. Nitesh, you would like to add anything?
I agree with what Dr. Keki and Dr. Maskati have said so far. I mean, that's the reality. But we may also start thinking about, the break, but also vision therapy at some point. Because I think vision therapy would be an ideal situation, because everything is changing. The modern world is arriving. We're not going to get away from it.
No.
So we may have to start practicing vision therapy in order to look at convergence, accommodation, all that, which Dr. K.K. Mehta earlier on mentioned. Because without that, I think we will have a big problem.
Those are fundamentals which you very often forget over a period of time.
Yes, binocular vision is very, very important. It is important there.
Dr. Bruce, any take-home message?
Oh, gosh. No. I think that everyone's covered everything pretty darn well, so it looks good. as I said earlier, my opinion is to try to get these kids as early as possible. Try to get the parents convinced. We keep brochures. I've got graphs. I've got stuff to show the parents, websites that they can go to. Really educate the parents as to what the possible consequence is of not treating the condition as soon as you can.
So, Dr. Keki, being the senior most ophthalmologist with a lot of experience, do you see a lot of retinal, issues in your practice? And on an average, how many patients are myopic?
I think the usual average is between 20 to 25%.
Are myopic?
Usual average, yes. But as you mentioned it correctly, the myopia doesn't worry us for the numbers. It worries us of what's going to happen over a period of time. And to make matters worse, now the application for near point activities is significantly more than what it was, say, 20 years ago. So what used to happen 20 years ago and the progression of myopia will no longer be true now. Now the curve will have a much more steeper curve. It's like the COVID curve in Bombay, rising.
Dr. Quresh, you have seen a lot of complications as well being a corneal surgeon. So when prescribing your patients on any modality of contact lenses like soft lenses or Orthoke or anything else, what is your gut feeling? What is your
No, I've seen a sea change over when I started practice in the mid 80s. The acceptance value for contact lenses. Contact lenses was something which was given to children only when they went to college, because before they go to college, they couldn't put in and remove contact lenses themselves. They're supposed to be immature, and they would cause complications. So all the ophthalmologists also advise the patients that till your child goes to college, no wearing contact lenses, big no, you must wear glasses. And the kids would rebel at their parents and at the ophthalmologist, but it was a huge no. It was sea change to now where we are actually telling patients to come into Orthoke, I think as early as what, 7 years? Nitesh, I think, is doing it even earlier than that. Nitesh, how many years? Earliest kid?
5.
Earlier, I mean, I'm 4 years of age now.
4 years and 5 years.
Yeah.
So kids are going in for contact lenses at much earlier years. But the safety has increased. Our knowledge of how to look after visual hygiene and contact lens cleaning solutions, all that has really made a revolution so that we can safely prescribe contact lenses for younger kids. But I think that webinars like this, the average ophthalmologist has no clue of the myopia epidemic which is going to come and hit all of us. And it cannot be only myopia specialists who are going to be tackling this. It has to be the average general ophthalmologist who has to tackle myopia at his own clinic, or the average general optometrist who has to tackle it also. So we need to join hands like never before between the ophthalmologists and the ODs and work hand in hand, because it's not one person's baby. I can give atropine, but I may not be so great at doing Orthoke or the newer contact lenses that are coming in. So we need to work hand in hand, and there is, at least in India, there is a little bit of a mistrust between the optoms and the ophthalmologists, and that really has to go if you have to control myopia across the world.
A quick question, Dr. Bharat. What is the role of Orthoke in recurrent myopia following a LASIK procedure?
Are you saying that can we do Orthoke after LASIK procedure?
You see, your new lenses should work much better.
Yes, they do.
Worked out.
Yeah,
so I'm wondering, is there any, because I don't see many references to that.
Yes, there's only very few of us doing them at the moment. So on post-LASIK patients, there are very few. I think, Bruce, you've done a few, haven't you, Bruce?
Yes, quite a few.
Post-LASIK, yeah. So we are very few, around maybe a handful of us are doing those. But they are quite successful. I've had no issues with them. I'm getting patients traveling to me from all over the world when they've had LASIK and having myopia coming back, or their RX is changing in different ways. So again, Bruce, you can say what you feel on that.
Yeah, I started doing it with standard trial lenses and fitting post LASIK that way with a very flat base curve, obviously, and a steeper periphery. But now that we have available the computer-generated lenses that we can actually sit there and design, we can all the way down to quadrant specific. So a lot of these LASIK patients that I've seen, not a lot of them, but some of them have displaced treatment zones, and it's pretty hard to get a standard kind of an Ortho-K lens to work well on that patient. And so with these computer synthesized designs, we can actually fit that cornea or that lens right to the cornea and do a very good job of, you know, I've done up to 3 diopters. Over 3 diopters, it gets a little testy. And stability is a problem sometimes with the higher progressors that have gone to 3 and 4. It doesn't last the full day, and I'm not sure what the reason for that is. But I have not had good success on post-RK patients. Those are just all over the place, and I cannot figure that one out.
Yeah, in my case, I don't fit any post-RK.
Have anybody any experience of applying Ortho-K lenses as a means of stabilizing the myopic cone in C3R patients? Specifically C3R patients done within the first 3 weeks of application of C3R. It's something not really commented upon. There are very few papers on it. There's some Europeans who have done papers on it. Essentially where the C3R causes the cornea to destabilize. It literally makes it more jelly-like. And using the Ortho-K lens, you use it like a mold. I read an article about it, never saw it again after that. Any experiences?
Sami Al-Haj did a research on it. I think Bruce will verify that for me.
Yeah.
And
That's
he
correct.
had good success with it.
He showed that if you do corneal molding after C3R, then it actually will mold the stroma as well as the epithelium. Most people agree that most of the change in orthokeratology is in the epithelium, but Sami says that it actually and has some topography to indicate that after molding after C3R, the procedure, the Ortho-K procedure, the lens can be removed and it will last for up to 3 months. I don't have any personal experience. The only experience that I have is after cross-linking, is that I need to wait 6 months. I have tried several times to fit an Ortho-K lens on a cross-linked patient in the first month, 2, 3 months after the procedure, and the epithelium comes off, and it's terrible. And so I don't even attempt it until 6 months post-procedure, and even then I will get some excess staining, typically not to the point where I have to stop the treatment. And I've done it a lot on form-fruste keratoconus, where you don't have a real severe keratoconus going, and vision with glasses or soft lenses just isn't adequate, and we'll do those patients, and they're very, very happy with that.
Thank you.
Thank you.
Any last words, Dr. Maskati?
No, I think we have all exhausted the topic very well, and hopefully the viewers have exhausted their questions. So
wonderful. So thank you very much, all the panelists. I'd like to thank of course the audience who have taken time and listened to us after so many webinars happening throughout the day and almost every day. Then of course thanks to Entot Pharmaceuticals for giving us their expertise to telecast all this. Then MF Laser, Dr. Bruce, Dr. Matthew Martin, Padma Shri, Dr. K.K. Mehta, Dr. Nitesh Barot, and Dr. Kuresh Maskuti. Thank you very much. It was nice.
Thank you. Thank you all.
Thank you.
Thank you.
All right.
Okay, bye. Bye all.
Bye. Keep safe, all.
Till we meet again.
Sure.
Yep.
Thank you.